All right. Hello, everybody. 1 o'clock on the dot. So we are going to get started with this week's office half hours. I'm going to try very hard not to touch my eye because I've got something in it and it's driving me crazy. But it's not cool to be distracted, right? So I'm going to try to stay focused on you and on the matter at hand and not on my eye that I just want to dig at. So that's what's new with me. If you are here for the free coaching and you are here live, not catching this on the replay, and you'd like some free coaching, just raise your hand, comment in the chat, and I can promote you to a panelist and we can work it out in real time. But otherwise, I do have some questions that were sent in and we will talk about those. But of course, before we talk about those, I want to talk about some stuff that's on my mind, right? So this is like my little fireside chat that I do on Tuesdays. And you may know that in being a nurse means a lot of different things, right? Being a nurse practitioner means a lot of different things. And one of the roles that I have, one of the hats that I wear is as a nurse investigator for the Board of Nursing. And there's something that I've seen actually come up in a bunch of cases that really applies to all of us, right? Because if you write a note in a patient's chart, this applies to you because theoretically, even if you're not the one being investigated, there's the chance that your note might come up in a case, right? So sometimes in the process of doing an investigation, I might ask for all of the notes between this date and that date. So it's all of the notes, right? So it could be anybody. And so, sometimes it's like speech language pathology, sometimes it's dietary nutrition stuff. A lot of times it's nursing stuff, but like everything kind of comes up. So something that I see often and that I think makes such a big difference as a clinician, I feel this way, as an investigator, I feel this way, and really as a patient, I would feel this way too. And this is another one of these things we are not taught in school. Nobody has any kind of like preparation for this, but it's the importance of images, right? And when I say images, I'm not talking about x-rays. Those are important, but we're taught that in school. So x-rays and CTs and MRIs and stuff. We get a handle on that in school, and obviously, or I hope it gets a little bit better as you're out there in the world in practice. But I'm talking like pictures, right? So as an investigator, I've had some cases that have the pictures have made the difference. They have made the difference in terms of, obviously I can't give you a lot of details, but they've made the difference in terms of really clarifying what is happening, right? It's the saying pictures worth 1,000 words, so true in this case. And, the words are one thing, but words are biased, right? Whatever, we can all kind of choose different words that are going to slant things. And we might be describing the exact same thing, but our word choice can slant things and make it shift kind of one way or another. They say also that if it's not in the note, it didn't happen. Like legally, I think that's true, right? But sometimes just because it's in the note doesn't mean, right? Like, so there's a mission, on purpose, and sometimes there's a mission just completely we're swamped and things don't get into the note. That can happen, right? But when there's a picture, then you've got this, it's almost as good as being there kind of evidence, right? So this is true also as a clinician, especially with wounds. I so often, when I worked for like a big corporate healthcare system, so I was seeing patients that were then being seen by like a million other providers within the same system. So we were all in the same chart. Taking pictures of a rash, taking pictures of a wound that I was going to have a patient come back in a week or a couple days or whatever the case was for either a dressing change or for evaluation. Cellulitis, I feel like I saw a lot of cellulitis, more than the average in our practice. I don't know if all the cellulitis patients found me. Cellulitis is a good one because you want to mark the edges of the wound, right? When you see them. So somebody's got, I don't know, cellulitis on their hand, right? So you kind of draw, you get your little surgical marker out, you draw your little line, okay? And that's good. And you can get your little tape measure out, right? And get a nice approximation. It's, 2.5 by 2.5 centimeters or whatever. It's superficial, whatever. Um, erythematous, warm to the touch, non-blanching, whatever your words are that describe it. That paints a picture. But the words that I might use to paint the picture, and then the way that I write that, and then the way that you read it, we might end up, right, with kind of two separate things. But if there's a photograph, boom, that's what it looked like on this day at this time. That's what it looked like. And if you've got someone with cellulitis and you're kind of concerned, like a little extra concerned about this person, maybe it's covering a big area, or maybe the patient is diabetic. And so you're not sure how well they're going to respond, and you're hoping that like oral antibiotics are going to be the ticket, but it might not be, but they're right on the borderline. So you say, okay, do this and then come back like 48 hours. Marking the edges is a good practice. Don't stop doing that if you're doing that, but take a picture and put it in the chart, because then you've got it in black and white, right? And we're not taught to do that in school. It's another one of those things that somehow there's so many other things that are more important to be taught, but taking photographs is not really a big one. And so it's nice for me. I always like to use that as an opportunity for small talk with a patient. I say, oh, they never taught me how to be a photographer in school, but you want to put something in the picture. So when you're taking a picture and you're putting it in the chart, in the note for your visit, you want to have something for reference to, because especially if it's like a rash or cellulitis that's over a big area, if you just take a picture of it, like that might not do the whole trick, right? So you want to have something in there for reference. So if you've got like the little wound tape, right, the measuring tape for wounds, put that bad boy right there, right next to it, so you can see, okay, boom, boom, right? Another thing is you want some kind of patient identifier on there. So if you have labels, I see this a lot, labels for the patient's visit, right? So it's got the patient's name, date of birth, and the date of the visit. You put that right on the thing so that that's in the picture. So that if for some reason that picture were to be taken just on its own as a standalone thing, you could see, chances are, now it's not completely conclusive, right? Because you could put a label with your name on me right now. It doesn't mean I'm you, but it's as close as we're going to get, right? But it's one more thing that's going to make it a little bit more clear. And when we need that information, it's going to make it better for everybody who needs to access that information for any reason. So take pictures. Take pictures of things that get the patient's consent, right? But take pictures of the things that are a visual issue: rashes, cellulitis, wounds. If you take sutures out and it's a little iffy or whatever, or if it looks pretty good, but it's in an area where there's a chance that it could get a little bit, it could open up, right? Like, so if it's like, I don't know, like stitches on a knee or something like that, right? Take a picture to say that when I took these out, they looked pretty good and the wound was healed, it was fully granulated, there's nothing, just so that you've got that, right? It's extra documentation. It's going to be as objective as is possible. And it's going to be something that's going to be good for all persons involved. So whether it is other providers who have to read the note, whether it's the patient, for whatever reason needs to refer back to that, or, God forbid, in the worst case scenario, if there was some sort of question, serious question about where things stood, this is something that's going to work in your favor and give you that little extra layer of protection. So that's a big one, right? I want to make sure that you are including photos in your notes where it makes sense to do that. It's also going to make it easier for you. Like I said, if you have a patient, even with a relatively simple thing like a cellulitis, and you're going to have them come back in a couple days or a week to assess their response, this is going to make it that much easier. So it's going to make your job a little easier, right? And when you have a more focused visit, when you do things that are going to make your visit that much more focused and kind of stack the deck that much more in your favor, it's also going to help with your time management. You're not going to have to reinvent the wheel. It's simplifying that process, because you can just look at, what did this look like last time? Or if somebody else has to see the patient for the follow-up, maybe you're off next week, they can look and see where things were, and then they can look at where things are today and make their judgment call and adjust the plan as needed. So photos, it's going to make a big difference. So, question that came in, and this is a charting question. It's also a time management question because of the nature of it. Can you give a little guidance on how to chart on complex patients? Oh, yes. Of course I can. So, in the primary care world, and as family nurse practitioners, which is what I am, and probably many of you watching are, we tend to work, especially in like first jobs out of school, we tend to work in a primary care setting. Not always, not forever, right? Sometimes people shift and go into specialties, but being trained as an FNP, as a family nurse practitioner, kind of sets us up for working in a primary care setting. And when we do that, um, it means that anything is up for grabs. You know, if you work in dermatology, you're not going to be dealing with visual acuity. You're not going to necessarily be dealing with blood pressure, you know, things like this. Um, you're not going to deal with an ingrown toenail or gout, right? You're going to be dealing with skin and skin related stuff. But if you're working in primary care, any of those things could come up, maybe even all in the same visit, right? Even when the visit is for a 1 week follow up of cellulitis. And then they're like, oh, but you know what? I've got this foreign body sensation in my left eye. And I think my right toe, right great toe has an ingrown toenail. So, you know, all this stuff. So when patients come in a primary care setting, especially if you work in an FQHC, which is a federally qualified healthcare center, so these are patients who they tend to have a lot of stuff that needs to be addressed. And these may be patients, although it's true in primary care too, when you've got patients who have been out of care for a period of time, or are getting kind of reestablished or getting back in the swing of seeing primary care on a regular basis, patients with multiple chronic conditions, so diabetes and hypertension and obesity, like the trifecta. You've kind of got to deal with all those things at once. And then sometimes you get these very complex patients or with a really long history. And then they also bring an acute concern to the visit, right? It's tough. The more you do in the visit, the longer it's going to take. And the longer the visit takes to conduct, then the longer it's going to take to document. In a perfect world, in a primary care setting, about 10 minutes for an issue, right? At least to get things started. You may have something that will require follow-up in another week, like a cellulitis or gout or something like that. But it's going to take a good 10 minutes, at least, sometimes more than that, but at least 10 minutes to really understand what is going on today and where we want to kind of focus our energy. Maybe build a differential diagnosis or maybe come up with something definitive, but 10 minutes at least, right? So if you're scheduled for all patients at 15-minute visits, you're not going to be able to cover 5 things in a visit. If you are scheduled for 30-minute visits and people come in with 10 or 20 things, I tell the story often of my colleague who had the patient with 19. I think that's the record breaker. If you've seen more than that, drop a comment, let me know. But right now the bar is set at 19 concerns in one visit. The more you cover in the visit, the longer it's going to take to document. So how do you chart on them? Well, whatever you're covering, you need to document. So boom, 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 boom. You don't have to write a paragraph on each concern. You can write a couple of sentences and really distill and simplify. You don't need to put the entire history, especially if this is a patient that has been seen before. So you're getting incremental history every time you see them. But you'll need to document on each thing. And the real issue is, to my thinking, not how long it takes you to write the note or how long it takes you to conduct the visit or those two things together. It's deeper than that, right? You need to take a longer look. And the issue is, why don't you have more time for these patients? If you have a lot of patients who have a lot of concerns, and this is kind of how it is, decisions need to be made about how much time you have for these visits. In a primary care setting, in a lot of cases, we will have acute visits and we will have follow-up visits and we will have like a physical or new patient visit, right? Sometimes you get more time for like a new patient visit or a physical. And these acute visits or even a follow-up visit, it might be like 15 minutes and you might get like 30 or maybe even 45 if you have a really cushy schedule for the longer visits. But if you're finding that all of your patients are coming in and they've got legitimately, 3, 4, 5 things that need to be talked about, and you don't have enough time, and this is a trend, then that's something that needs to be brought to the decision makers. So what I would say is really when it comes to the question of charting on these complex patients, it's not about you. It's not that you are necessarily doing something wrong, that you're not doing enough, like you're not fast enough in the visit or you're not fast enough with your note. There are ways that like you can get faster with each of those, but like if patients have that much that they're bringing to the table, it's just going to take more time. And there's not really a way to rush that or to shortcut that. So it's not you. It's the way the system is set up. So now what you need to do is you need to turn those powers of advocacy that we usually use like on the patient, we need to use those for ourselves. So having these complex patients and having charting challenges because of that really isn't about the visit or the note. It's about the system. So the first thing that I would do is get objective data, because when you are swamped and you feel like you are up to your ears all day, every day with patients and requests and task lists and all this stuff, then it doesn't take much to really feel like you are just completely over the line. That may or may not be the case. So get some objective data. If you really think that it's that you need more time with these patients, then pull your records from the past 5 days that you work. So the last, or whatever your week is, if you work 4 days a week, 5 days a week, but the last, say, 1 or 2 weeks, and just look at each patient. You don't need to put a little report together, but you don't need any patient identifying information. But just put down this patient in this slot and how many concerns we went over in that visit. Maybe even what they were too, that if you want to be a total overachiever, but even just the number of concerns. So this patient, 3 concerns, 1 concern, 10 concerns, 19 concerns, whatever it is. And then look at that for like a 1 week or a 2 week period and see what you're looking for are these things that were just blips, but they came at a really bad time? Or is this really a trend? And usually 3 or more occurrences we would consider a trend. So if you have 3 or more occurrences in that period of time in a week, or 5 or more in 2 weeks, then that's something that you can say, okay, this is an issue. This is bigger than just me. And that's something that you can bring to leadership. You can bring to the decision makers, and it will help you to plead your case, to advocate for yourself. I need more time. I either need more time for all of my visits. I need a couple of slots held for these chronic care visits or these complex visits or whatever you want to call them. It's kind of like the way in a parking lot, some parking spaces are bigger, right? Or they have the compact spots, right? A compact spot would be like a short visit on your schedule. Patient with 1 concern, upper respiratory infection, UTI, right? Short and sweet and to the point. That would be like a parking lot with a compact car slot, right? But then some places you have these like, and maybe it's only in like truck stops, but like they have the great big parking spaces for like tractor trailers. Those are your patients that have the 19 things, right? They've got a trailer full of stuff. They need more time. So you could ask, once you have this objective data, and it's not just you, right? It's the system, and we need to come at this. Me working harder isn't going to fix this. It's just going to burn me out. So from there, you ask for what you need, and you tell them why you need this, and you tell them what can be gained from getting this, having different slots, either giving me more time for every patient or hold a couple slots in the morning and a couple in the afternoon that we can use for these complex patients, so a complex visit. And then what the reason for it is, what the benefit is of giving you what you want, and what the drawback is if we don't. Because if this continues, I'm going to be burnt out. I'm going to be behind with my charts. When I'm behind with my charts, then you're behind with your reimbursement. It's a domino effect. On the flip side, if we can get these patients scheduled a little bit differently and kind of flip that around a little, then I can get my notes done faster and you can get your money faster. It's not, unfortunately, it's not a guarantee that they're going to bite. But I feel so strongly about the fact that we need to advocate for ourselves. And the first time that we advocate for ourselves often goes unheard. But the second time, the third time, the thousandth time as an industry, we start doing this, or we increase how much we're doing this, and we start raising our voices and we start saying what we need. There are more nurses and nurse practitioners than administrators. We outnumber them, right? So if we are able to keep saying this and keep beating this drum, at some point the scales will shift. I wish it could be faster. I'm still, like in the lab working on a solution for that. I don't have a solution for that yet. If you have ideas, drop those in the comments. But it's important for us to talk about these things and to ask for these things and to say, this isn't working. It's not working. And over time, if enough of us do that and we keep it up and we keep advocating for ourselves the way we know how to advocate for our patients, that's where change will happen. But we have to have faith and we have to stick with it. And if you are in a situation where it is just completely not working, then you need to look at your other options. And there are other options. I know that some of us live in areas that are saturated with NPs, but there are other things that you may not be in a position where you could just move to a state where there's a need for NPs, right? You may not be in a position where you can necessarily change jobs at the drop of a hat. You might have a contract, you may have reasons for staying. But that doesn't mean you're going to stay there for the duration of your career. At some point, you can leave. And so that may be an option as well. It's not enough to just throw our hands up and to say this sucks. That's a start. We should say that. But that's not enough. We have to do a little bit more. Advocating for ourselves is a big part of it. That's why I'm here talking to you, right? Because I want to help you to be able to do that. Another piece that goes along with that, that also has come up recently, is late policies, right? How late is too late to be seen? And what do you do when a patient shows up late? My rule of thumb, so I have my rule of thumb that 10 minutes for a concern in a primary care setting. My rule of thumb with late arrivals is, I think it kind of is sort of like compromise that means I would love it if it's like, no, if you're late, you can't be seen, but that's not always realistic. If more than 50% of the visit has passed, then they would need to reschedule or like wait. They can hang out and wait and see if there's like a no-show, and they could kind of pop into that slot. But if you have a 15-minute visit, then after 7 or 8 minutes, yeah, we're gonna have to call that a no-show. If you have a 30-minute visit, you get, I guess, 15 minutes. But after that, some people have no policy, so the patients can show up whenever. And I say, that is tough. It's also tough for the patients after that appointment who have showed up and they are on time. Should they have to wait because the 1 o'clock was late? I don't think so. I don't think that that's ethical. I think that if the policy is that we will see you, even if you're like, an hour late or something, right? That we will still get seen. Okay. But it's the people who are here on time are going to get priority because they're here for the appointment that we held for them and they showed up for it. So that's a little bit, and patients don't like that. And you have to, each situation you have to navigate a little bit too, because there can be more to the story that can make a difference. But in a general sense, I think that 50% of the visit after that, we have to look at alternatives. So can they be seen by another provider who has an opening, or can they hang around and wait for a no-show? And in a worst case scenario, we see them at the end of the session, so that they can be seen, but not the minute they walk through the door. The other thing is, if you have a patient that shows up late, so let's say you have a 20-minute visit and they show up 5 minutes late. This is like a little food for thought. Do you, in a 20-minute visit, patient shows up 5 minutes late, do they get the full 20 minutes of your time? Or do they get the full 20 minutes minus however late they were? Do they get the remaining 15 minutes, for example? That's how I do it. Because that's like the most black and white. Again, if there's a patient emergency, that always kind of, trumps everything. And there can be cases where an exception is appropriate. But in a general sense, it's like when they interrupt a show already in progress on TV, if you're old enough to remember that. I don't even know if that happens anymore. Probably. I don't know if there was some sort of breaking news. But if you think about that, then they go back to the show and the show like kind of kept playing. Like when I was a kid, I remember that happened with uh soap operas a lot, right? So the soap opera plays for an hour. If they have some breaking news and they need to interrupt, they do their interruption, they say whatever they have to say, and then they go back to the show that's already in progress. That's your visit, right? So when the patient shows up 5 minutes late to a 20-minute visit, that 20 minutes has still started to go. They're just not there for the first five, right? I think that's fair. And then, of course, patient emergencies are always an exception. But if it's an emergency, is primary care really where they should be seen? That's for another day. So those are all things to think about, right? And those are all ways that are food for thought or things that you could just say, okay, I'm going to start doing it that way, effective now, immediately. But those are all things to get you thinking about how do you approach these things and what works for you? Because probably no one has asked you. If you're watching this, you probably haven't been asked that, right? And you haven't had that opportunity to have that conversation. You might have to be the one to start the conversation. You might need to be the one that gets that objective data and brings it up and has that uncomfortable conversation with leadership and says, you know what? This isn't working. I have a proposed solution and we can negotiate, but I have a proposed solution because I've identified the problem, I have objective data, and here's what I think we should do. That's also part of your responsibility. And that's also something that we don't learn in school, right? Surprise. So there's always one more thing, just like your inbox, there's always one more thing that you need to do. But this one benefits you. This one can make your work life better. So that has been Office Half Hours. I love to talk about this. I love to answer your questions about your charting and your time management challenges. So definitely send me a message, shoot me an email, drop a comment, whatever works for you. If you can't make it, you can always catch the replay. I get it. It's Tuesday afternoon, so not everybody has the time to do that, but the replay, that's what it's there for. So if you have questions, send them to me. Otherwise, I will catch you next time, next Tuesday, at the next Office Half Hours. This has been Jessica signing off. Take care.